Hi, my name is Nick Gualtieri. I'm one of the residents at UT Health Science Center at San Antonio Emergency Medicine Residency, and I'm creating this presentation to discuss the stroke assessment in pre-hospital environment. As we get into this presentation, we will discuss initially the EMS role in assessing for stroke. We will then discuss the different assessment tools that exist, and then we will also demonstrate the physical assessment tools. The role of the pre-hospital team in the setting of stroke, of course, involves stabilizing airway, breathing, and circulation if necessary. Oftentimes, if stroke is what you're concerned about, those interventions are not always going to be necessary. So early recognition is key, and we'll discuss tools to help recognize stroke. Um, just as important as recognition involves the initiation of stroke protocol. This often involves alerting a designated hospital that you are concerned for a stroke and transporting the patient to the nearest stroke-ready hospital to help them get the treatment that they need. These are the three physical assessment tools that we will discuss to help screen for stroke in the pre-hospital environment. First, the Cincinnati Pre-Hospital Stroke Scale. Second, the BFAST exam. And third, the VAN assessment. The Cincinnati Pre-Hospital Stroke Scale is the most commonly utilized pre-hospital stroke assessment. The CPSS evaluates for any facial droop, arm or pronator drift, and for any speech deficits. When assessing for facial droop, you can ask the patient to smile. If you notice either side of the face appearing droopy or even asymmetrical at all, this should raise your suspicion for a positive finding. When assessing for arm or pronator drift, you should ask the patient to flex both of their arms at the shoulders directly in front of their body to at least 90 degrees and ask the patient to shut their eyes. And if you notice either arm drooping downward, drifting downward, or experiencing any sort of asymmetric strength, this should raise your concern for a positive finding. When assessing the patient for any speech deficits, it's easiest to have them repeat a simple sentence. The one that is most commonly used is, "You cannot teach an old dog new tricks." If you notice the patient slurring their words, verbalizing words that you did not ask them to state, or failing to reproduce language at all, these would all be concerning exam findings. Validation studies have shown that if any one of the three aforementioned tests is abnormal, the probability of stroke is approximately 72%. And if all three tests are abnormal, the probability of stroke increases to greater than 85%. This is an example of utilizing the Cincinnati Pre-Hospital Stroke Scale. First, to assess for any facial droop, ask the patient, "Can you please smile at me as large as you can? Show me all of your teeth." This is a normal finding. Any abnormal finding would include drooping of one side of the face or the other, or any asymmetry that you note about the mouth. Even the maxillary cheek area can be affected, but the most helpful area to assess is the lips and the lateral aspects of the mouth. Secondly, we'll assess for any arm drift, also known as pronator drift. Ask the patient to please extend or flex your arms in front of you greater than 90 degrees. Hold the palms up to the ceiling and hold this position for 10 seconds. This can be a very subtle finding, but if you even see the slightest amount of drift on one arm or the other, that should concern you. That was obviously a negative test there. And then thirdly, assess the patient's speech. Specifically, are they able to rehearse or repeat a short sentence back to the examiner? "Can you please repeat after me? You cannot teach an old dog new tricks."
You cannot teach an old dog new tricks.
And also a normal finding there. But any slurring of the words, failure to say the words correctly, or incorrect words repeated would be a positive finding. The BFAST assessment is similar in the CPSS in that it utilizes test to assess for facial asymmetry, weakness, and visual field deficits. The BFAST assessment also adds 2 steps to assess for signs of posterior stroke. When applying the BFAST assessment, I like to think of the FAST components initially. The F, A, and S are all the same tests that we used in the CPSS. The F stands for the facial droop, using the same mechanism as described in CPSS. The A stands for arm or pronator drift, utilizing the same bilateral flexion at the shoulder that we had discussed for the CPSS. And the S stands for speech, specifically if there's any slurred speech or if there's any incorrect words verbalized or failure to reproduce language. The T at the end of the FAST stands for time. This is to help prompt the examiner to establish the time since symptom onset, meaning at what time did your symptoms begin, how many minutes or hours have elapsed since the time your symptoms began. The BFAST assessment can be differentiated from the Cincinnati Pre-Hospital Stroke Scale by the implementation of the balance and eye assessments. These are both signs that are helpful to evaluate if there's any posterior stroke occurring. The B stands for balance. This can be best tested by utilizing finger to nose testing and heel to shin testing. If possible, you can also ask the patient to trial ambulation and just generally see how the patient is walking. The E stands for eyes. This can stand for a lot of different findings in the eye. Certain that could be possible include if there's any disconjugate gaze, meaning the eyes don't appear to be looking at the same location, or they seem to be crooked in some fashion. It could also indicate to assess for any abnormality in extraocular motions, meaning when you ask the patient to look in a certain direction, do they have any asymmetry in their gaze as well. You could also ask the patient, are they having any visual disturbances, any blindness in a certain field of vision? Do they have complete blindness in one eye compared to the other, or do they have decreased ability to look in their left visual field in both eyes? All of these would be concerning findings for the eyes being affected by possibly an underlying stroke. We will now be showing an example of the second field test to assess the possibility of stroke. This is the BFAST. I start out with the FAST portion of this test. The F, A, and S for facial asymmetry, arm or pronator drifting, and speech were already exemplified in the prior video. With positive findings in either of these, you'll be prompted to ask the patient, when did your symptoms onset?
3 hours ago.
And that establishes time since symptom onset. Additionally, positive findings may prompt the examiner to assess for the B component of this. The B stands for balance and the E stands for eyes. We can assess balance by finger to nose and heel to shin testing, exemplified here. Patient, please take your right index finger, touch my finger, and touch your nose. Touch my finger, touch your nose, touch my finger, touch your nose. Any unsteadiness with that or inaccuracy with touching the finger or back to their nose would be a concerning finding. You would repeat those testing on both sides. Similarly, with heel to shin testing, you ask the patient, please touch your knee with your heel and run your heel down your leg, and repeat that on both sides. That was a normal finding, but any unsteadiness with the translocation of the heel, moving off the center of the leg, or failing to accurately touch the knee with the heel would be a positive finding. We'll then go on to assess the eyes. First, you'll assess the extraocular motions by holding your finger in front of the patient's face. Excuse me, patient, please keep your head still and just follow my finger with your eyes. And you'll assess the eyes through all extraocular motions horizontally and vertically, looking for any nystagmus, any disconjugate gaze where the eyes appear not to be looking in the same direction. And finally, we would also assess for any visual field deficits. The way to assess for this is to ask the patient to cover one eye with their hand and assess visual fields in all 4 quadrants. You can do this by holding fingers in each quadrant and asking how many fingers you're holding up. Please keep looking directly at my nose, do not move your eyes, and tell me how many fingers you see.
I can't see under the hat. 2.
Good.
2. 1. 3.
Oh, that was an abnormal finding, and I'm now concerned for a posterior stroke. The hat is skewing the results a little bit, but you might ask the patient to remove a hat. And you would repeat the testing in both eyes. Particularly concerning findings for stroke would be especially if the patient has absent vision on either the left or the right side that is seen in both eyes. That finding is known as homonymous hemianopia and would raise the concern for stroke, but truly any visual field deficits that would not be part of the patient's baseline would be concerning for stroke, and a posterior one. Now that we've discussed both the Cincinnati Pre-Hospital Stroke Scale as well as the BFAST assessment, it is important to touch upon what are VAN signs. VAN stands for vision, aphasia, and neglect. And this is a specific set of evaluations that an examiner should initiate if the patient is found to have any weakness or arm drift or pronator drift specifically on their initial stroke assessment. If there is the presence of any arm drift or pronator drift, this leads to the possibility of an underlying large vessel occlusion. So again, whenever there is any arm drift or pronator drift present, the examiner should utilize the VAN testing. The relevance of this, again, indicates any underlying large vessel occlusion, and if there is underlying large vessel occlusion, this specific type of stroke can benefit from a specialized form of treatment called thrombectomy, which not all stroke centers have access to, and usually only the highest level stroke scales will be able to implement. This can have a huge impact on the pre-hospital care because it makes very specific transfer or transport logistics involved, where the pre-hospital team needs to know exactly where to go so that the patient can get their possible thrombectomy. The purpose of this slide is to relate the findings on the stroke screenings, including the CPSS and the BFAST, and when to take these findings and then apply VAN criteria. Just to summarize, for the CPSS and BFAST, if we have positive findings here, as well as a last known well time within 6 hours, as well as serum glucose levels between 60 and 600, we do have the possibility of initiating stroke protocol. Additionally, if we have positive arm drift, also known as pronator drift, if we have that present, the VAN criteria should be applied. And the differentiating timepiece for this is that LVO criteria and code LVO can be initiated if we are within the 24-hour time frame. So just to clarify, in order to activate a regular stroke, code stroke, last known well time must be within 6 hours. However, if there is concern for LVO, we can extend the last known well time to up to 24 hours. And this is because thrombectomy is a possible treatment up to 24 hours from symptom onset, whereas the regular stroke protocol, and specifically the implementation of any TNK or any other clot busting medications, those normally have to be done about within 6 hours or so. So just to reiterate, the VAN testing is the testing implemented when there is concern for large vessel occlusion noted by either arm weakness or pronator drift appreciated. We will pursue VAN testing by looking at the patient's vision, looking for whether aphasia is present, and looking for whether neglect is present. For vision deficits, specifically, we'll look for any homonymous hemianopsia. This is when the vision is lost in either the left or the right visual field in both eyes at the same time. Disconjugate gaze is also a visual finding that is concerning for LVO. When we assess for aphasia, specifically, is the patient having receptive aphasia, meaning demonstrating inability to understand or perceive language? Additionally, are they having any expressive aphasia, meaning difficulty producing language? And thirdly, we'll assess for neglect, which in my opinion is one of the most interesting findings in the setting of LVO. Essentially, it appears that the patient is ignoring a side of their body, or of course neglecting the side of their body. This can be checked by asking the patient to look toward both sides. You can hold your hand up on either side of their face and ask them to look at your hand. You'll notice that they are able to look at your hand or look toward their side, one side of their body without difficulty. But when you ask them to look toward their affected side, it almost looks like they're just ignoring your question or just not even making an effort to look. And they're really not doing it on purpose. They don't know that they're doing it. It's just a really interesting finding that can be seen in LVO. Finally, we'll be demonstrating the VAN testing to assess for the possibility of underlying large vessel occlusion using the mnemonic VAN, standing for visual disturbance, aphasia, and neglect. Visual disturbances in this category will be tested similarly as we utilize for the BFAST. You'll assess extraocular motions and visual fields in all four quadrants. If there's any visual field deficits, abnormal extraocular motions, or disconjugate gaze, you would have a positive finding. Secondly, assessing for any aphasia. This can be both receptive aphasia, where the patient doesn't understand what you're saying, or expressive aphasia, meaning the patient cannot properly verbalize words. This can be tested by asking the patient to repeat a short sentence. Can you please repeat to me, "You cannot teach an old dog new tricks"?
You do not teach an old dog new tricks.
This would be a normal finding. The patient clearly understands the words that are stated to her, and she repeats them properly back. Any abnormality in the repetition would be concerning. And if the patient doesn't respond to you or appears confused, that might indicate there's some underlying receptive aphasia. Thirdly, we'll assess for any neglect, which might be one of the more interesting findings here. Essentially, this is when the patient cannot acknowledge one side or the other of the body. To assess for this, the patient might be staring off toward one side and might be completely unable to acknowledge this side of her body. If I'm to come over to this side, she can interact with me. "Hello, do you see me looking, do you see me holding your fingers up on this side?" This would be normal finding on this side. But as I transfer to the affected side, "Hello, can you see my finger? How many fingers am I holding up?" The patient doesn't even make an effort to look this way. This is concerning for the presence of neglect. And finally, to emphasize some of the most important points of this talk. Firstly, arm and pronator drift is the most important physical exam finding in stroke screening. The presence of it should be taken very seriously. It should also be noted that it can be a very subtle finding, so any asymmetry or any drift noted at all should be considered positive and should prompt the examiner to move on to VAN testing. Secondly, all patients who have been found to be VAN positive and are within 24 hours of symptom onset with blood glucose within the target range, these patients should be considered for thrombectomy, should be taken to comprehensive stroke center and thrombectomy capable facilities. Finally, there are many conditions that can mimic stroke. Our goal is not to be specific, but rather sensitive. we want to initiate stroke protocol, and if we have an over initiation, that's something that we can live with. We can tolerate this. Our goal is to get all strokes screened into this protocol, and that should really be a huge take home point here. Thanks for listening to this talk, and I hope it benefits you in your work.